This presentation was recorded at the 2015 ANZICS ACCCN Annual Scientific Meeting.
And now I'd like to welcome Doran, homegrown here in Auckland, one of the senior staff nurses at Starship Children's Hospital Paediatric Intensive Care Unit. She has a long background in cardiothoracics and paediatrics and was instrumental in setting up the bereavement service at Starship Children's Hospital when the unit opened in 2003. She works closely with the medical and nursing staff as well as the Starship Grief Counsellor to ensure that bereaved parents are supported both during their hospital stay and during the first few months of following the death of their child. Thanks, Anne.
So a death should be managed as vigorously as a life. That's a challenge laid down to us by well-known Australian bereavement counsellor and educator Mel McKissick. This morning I'd like to share my experiences of caring for dying children in intensive care. I'll start with an overview of what palliative care in PICU involves and then present a case study. I'll then give a quick rundown on the bereavement follow-up service that we run in our unit. So do lots of exciting, dynamic, life-saving therapies in PICU. But the thing that staff often find the most daunting is caring for a dying child and their family. As most of you will know, it's not exactly a family-friendly environment, and we've had several babies die in exactly this environment. We're fortunate in our unit to have a great team of senior nursing and medical staff, many of who are here, who believe that caring for the dying is as valuable as caring for the living, so we get lots of support with making sure that things are as bearable as possible for families. So 70% of the deaths in our unit are due to a limitation or withdrawal of treatment. So what's often happened is we've done all the life-saving therapies and then found that the child is going to have a very bad outcome. Withdrawal of treatment may be extubation and or stopping of inotropes or ECMO. We'll sometimes do a limited withdrawal, so we'll stop inotropes or not escalate treatment or perform CPR, but continue with ventilation. This is sometimes at the parent's request as they aren't comfortable or ready for a complete withdrawal. So some of the reasons for withdrawal are inoperable congenital abnormality, particularly cardiac, dependence on invasive ventilation or cardiac support where there's no prospect of recovery, injuries sustained that are incompatible with life, or an unacceptable quality of life. So unacceptable quality of life can be very subjective, and the decision needs to be seen as one that's in the best interests of the child. So is PICU the right place for palliative care? 80 to 90% of deaths in Starship are in PICU. And we have about 30 to 50 deaths a year out of about 1,100 admissions. So most PICU deaths will happen within the first few hours of withdrawal of treatment, so the majority of these patients aren't going to actually make it out of intensive care. There's an average of 1 death a year on individual Starship wards, so because we do deaths so often compared to the wards, at the risk of sounding smug, we do it well, which is better for families. PICU are also better often able to provide good symptom relief due to the availability of medical staff. Most patients who do get discharged to the ward from PICU for palliation will have been referred to the palliative care team. However, if ward staff need after-hours support, they'll often refer to PICU. In 2014, there were 6 code pink calls to patients with end-of-life care plans in place. A code pink call is when ward nursing or medical staff have concern about a patient and want PICU input within 20 minutes. All of these children remained on the ward with support from PICU staff. So maybe better education and support of ward staff and end-of-life care would mean that child die in a more family-orientated setting. Should difficult conversations be happening with some families prior to PICU admission? A significant number of our patients have multiple comorbidities and are sometimes quite severely disabled. So a possible question is whether it would be more appropriate for end-of-life care planning to start out in the community. Just as the child is about to be intubated isn't the right time to expect parents to be making decisions as to whether this is in the best interests of the child. However, quality of life is very subjective, and disabled children obviously have as much right to treatment as able, so it is an ethical dilemma. So how do we allow a natural death in such a high-tech environment? Communication is probably the most important issue to consider, and this starts with the medical teams. It's important that there is a consensus of opinions before approaching the family, so the plan can be seen as one agreed on by all the healthcare team. We've learnt this by experience. It's embarrassing and distressing when the PICU consultant explains to the family that there's nothing more that we can offer their child, only to have one of the surgical teams come and announce we can do an operation. We also need to ensure that all the family are informed of the plan. Although the first conversation about withdrawal is usually with the parents, we'll also offer a further meeting with extended family so everyone has all the facts. We need to communicate what withdrawal of treatment actually means and how this works. A layperson's perception of turning off the life support is often quite different to reality and can be very anxiety-provoking for families. I can remember a non-nursing friend asking me, so do you actually just turn off a switch? These perceptions are sometimes influenced by what people have seen on TV, and we all know what amazing miracles happen according to the media. So it's important that we talk through the process. The child might not die straight away, which is what often happens, and they may gasp, which can be distressing both for families and unprepared nursing staff. Privacy. We'll try to move the child into a single room or an empty 4-bedded room. But, however, there is no privacy in PICU. Other families often know what's going on and are affected by this, and families in PICU get to know each other. De-intensifying. So we remove all unnecessary lines and equipment and make the child look more like their child. Comfort. We use morphine and midazolam infusions and boluses, and this is to prevent suffering for both the child and the family. Family involvement. Some families know exactly what they need to do when a family member dies. Others require a lot more guidance. Although we give families the opportunity to decide the timing of extubation, I had one mother who said she couldn't make a decision about when her child should die, so asked me to make it. I then suggested a time and we worked out a plan for the day. This mother also required a lot of direction on what she wanted to do for her child, such as washing and dressing. She was appreciative of my suggestions and felt that this really helped her to come to terms with her child's death. Anything goes. So we've done all sorts of things in PICU to support families' needs at this time. When a child dies late at night and the family from out of Auckland will put mattresses on the floor and the family sleep on the floor with the child in the middle. Probably highly against fire regulations, but sometimes we do push the boundaries. We've had families get married at the bedside and then have a christening prior to withdrawal. We had one young girl who had a chronic respiratory condition and had become BiPAP dependent. In conjunction with her family, this young lady had decided that her quality of life was unacceptable and she wanted to die, but she wanted a party, so we had a party. We had fairy lights and balloons and cake, and all her friends and family came. The following day we discontinued BiPAP and she died content and peacefully. Cultural and spiritual support. We have Kaiatify, which is for Maori families, Pacific Island support, and a hospital chaplain, and will offer a baptism or a blessing. But in the 2013 New Zealand census, 213 ethnic groups were identified, so it's unrealistic to expect carers to know in advance every detail of the cultural and religious sensibilities of others, but we can ask the right questions. And cultural safety is about being aware of our own cultural identity and not pushing it onto others. We also need to remember that we have a PICU culture of authority and control, and this needs to go out the window in these situations. Memories. So we have a memory book which is up there. Which parents can take home with them, obviously. We do handprints and footprints, and we offer a lock of hair and photos. And we have a lovely woman who comes in and does casting of hands and feet for our children for free. Coroner's cases are much more complicated and less family friendly, but a work in progress. We're always negotiating with the police and the coroners around allowing families the ability to do what they need to do to embark on a healthy grieving process, and this can be a real challenge. So what about the staff caring for these children and their families? How do we support them? A few years ago I did a literature review on the needs of PICU nurses when caring for children who are dying in intensive care. This research came from PICUs in Europe, the US, Asia and Australia and showed 6 very definite themes. Mentoring of inexperienced staff on bereavement care. On-the-job education and support from peers is vital. This makes the experience less stressful for nurses and improves quality of care for grieving families. There's always going to be a first time, and we try to ensure that there's plenty of support for nurses in this situation. The need for end-of-life care education and policies. Nurses who had undertaken education courses in bereavement care were more comfortable providing this care. In our PICU, orientating staff and nurses on new graduate programs get end-of-life education as well as update sessions when able. The need for culturally competent bereavement care. As I said earlier, we need to be aware of the wide range of cultures in our countries and acknowledge these. I do think this is something we're comfortable with fairly comfortable with in New Zealand, possibly due to the emphasis on cultural competence in nursing education. The influence of the piku culture. Nurses felt the need to maintain control of their environment over family. And do ICUs have a rescue culture? We're used to saving lives, not allowing people to die. In this age of institutionalised dying, it often seems that death is seen less as a natural event than as a failure in medical treatment. And some nurses had difficulty accepting that their role was no longer curative but palliative without experiencing a sense of failure. The ability of staff to manage their own grief. In recent surveys we've done in our unit, 70% of staff preferred to debrief with colleagues on an informal level. And this way of debriefing is supported by a recent article in the American Journal of Critical Care on promoting staff resilience in PICU. However, formal counselling should be offered. I also include self-care in the end-of-life care lectures I give, and we have a component of this in our annual team building days. Bereavement care is a positive aspect of PICU nursing. Some nurses expressed feelings of inadequacy and helplessness when a child died. Others saw it as a challenge. Personally, I feel a huge sense of achievement when I know a child has had a good death and that family and nursing staff feel supported and engaged in the process. So this is the story of Joe. Joseph was a 14-month-old boy of Maori Vietnamese descent. He was the only child of a solo mum, Moana. He presented to their local hospital on the 3rd of December for investigation of progressive weakness, and an MRI showed a cervical spine tumour. On the 17th of December, he was admitted to Starship for laminectomy and biopsy, and he was discharged home for Christmas and to await biopsy results. On Christmas Eve, Joe represented to his local hospital with possible aspiration pneumonia and worsening weakness. He was retrieved by the PICU transport team, intubated and ventilated. A repeat MRI showed cephalic spread of the tumour with haemorrhage. He had progressing paralysis and apnea. Histology was still pending, but likely to result in a poor prognosis. So end-of-life care planning began. A meeting was held with the oncology, neurosurgery and PICU teams to review the diagnosis, prognosis and develop a plan. The plan decided was to minimise Joe's suffering in the face of inevitable death, so a one-way extubation and comfort cares. Oncology, neurosurgery and PICU then met with Moana and her father to reiterate the diagnosis, including probable histology, and share the prognosis and plan. So Joe was then moved to a single room. The morphine infusion was increased to 40 mics per kilo. Moana contacted her extended whānau. For those of you who aren't familiar with the term, whānau is the Maori word for family. Moana was involved in all Joe's cares and washes and slept the night in bed with Joe in PICU. On the 28th of December, a second family meeting was held with the PICU consultant and nurse and the extended whānau. Extended whānau can pose challenges if they've not been involved in end-of-life discussions, and in this case, one of the grandmothers chose to go home at this point because she didn't agree with the plan. Moana and her extended whānau were doing all cares, spending time with Joe, telling stories about him and having a laugh. And Moana expressed her desire for Joe not to suffer longer than necessary, and a plan was made to extubate the following day, once all the extended whānau had arrived. So Moana and her support people spent the night in PICU, sleeping with Joe and in lazy boy chairs. Other family members were accommodated in Ronald McDonald House. Moana was asking questions about the extubation process, travel and funeral arrangements, and a social worker was called to assist with travel arrangements. Cultural and spiritual support were offered but declined as the family felt they were able to provide this themselves. Hand and footprints were done and other memories preserved. The following day, Joe was placed in Moana's arms. Extended family were present as per Moana's wishes. Some parents at this point have asked that extended family leave so they can have this time alone with their child. Joe was extubated at 11 o'clock. The morphine infusion remained in progress, and he was pronounced dead at 11:15. It was documented in the notes that he appeared comfortable throughout. Moana expressed that by being involved in the decision-making of time of extubation, she had some control over the situation. So Joe was then washed and dressed by his family. The relevant paperwork was given to Moana's support person. It's common in New Zealand for families, particularly Maori, to take the body of their loved one home to their marae as soon as possible. And a transferred charge of body form is required in this case if the funeral director isn't involved until the body arrives home. And Moana and her close friend then drove Joe home to their marae. In New Zealand hospitals, when a patient dies, a blessing of the room is performed prior to any admissions into that room. This used to be performed by the Starship chaplain or by kairawhai, but at 3 o'clock in the morning this isn't always practical, so it can now be done by anyone with a spiritual belief. We found that this can help provide closure for staff, and I find that even the most non-religious of staff insist that the blessing is done. So on the 24th of February, one of the Piku bereavement team members called and spoke to Moana. She said she was surprised at how well she was coping. She'd had time on holiday by herself, which helped. She'd gone back to work and was attending a grieving women's group recommended by her counsellor. She stated that she was grateful for the support that she'd received from Starship staff and Ronald McDonald House, and she thanked the consultant for her honesty in being upfront about Joe's outlook. Moana was given assistance requesting a copy of Joe's clinical record. So a couple of months later, Moana sent us a letter expressing her feelings about Joe's death. So I'll let you read some of those if you can do it without crying. So it's never a good thing when a child dies, but we can make it a good death. I wasn't actually involved in this child's palliation, but I'm proud of the staff who were. So we don't always get it right, but this is what we strive for. The goal of caring for a child who is dying is to make the most agonising of all life's events as bearable as possible for all concerned. So I'll now give a quick overview of the bereavement follow-up that we do in our piku for those of you who are thinking of setting up your own service in your units. And the thing that prompted me to develop this service was watching some parents walk out of intensive care without their child, and I wondered, who looks out for them now? They seem to be set adrift. So the purpose of bereavement follow-up is to provide an opportunity for relatives to ask questions about their child's care, illness and death, to provide an opportunity for them to talk about their experience and how they're feeling with someone outside their immediate circle of family and friends, to identify parents or other relatives, including siblings, who are having serious difficulty and assist them to get further help, to let them know there's an option of meeting with medical staff if they wish, to provide information about other supports and resources that are available in the community, and to identify areas for improvement of practice. So it's quality assurance for us as well. So 2 weeks following the death, we send out a sympathy card, which is signed by piku staff, a letter introducing the piku bereavement service and the Starship grief counsellor, a Beyond Words book, which is available on the Skylight website, which I'll show you later, and a pamphlet of community and online resources. 6 weeks following the death, we make a phone call to assess the need for further follow-up. For example, a family meeting with medical staff, counselling, community resources or support, or a blessing of the room. And we've had several families come in and just sit in the room that their child died in. So what the role is, it's supportive listening, information provider, contact liaison with piku, which is where their child died, interested inquiry about wellbeing, normalising of the grief experience, and an extension of the role of professional piku nurse. What the role is not, I decided we needed a happy slide here. We're not counsellors, we're not providing friendship or trying to give advice, and we're certainly not trying to cheer up the grieving person. So outcomes of our bereavement calls. So 70% of families are contacted, and the reasons for non-contact are transient families or those who've returned to the Pacific Islands. For those families we're unable to contact, we'll send out another follow-up letter with our contact details. We have 4 to 5 family meetings a year, and family meetings sometimes also involve the primary medical team as well as our piku consultants. But cardiology in particular may do a family meeting without piku involvement. We have 2 to 3 referrals a year to consult liaison. This team includes grief counsellors and other psychological support. And these referrals sometimes start as referrals for siblings. We have 1 to 2 other referrals a year to services such as genetics, and 4 to 5 referrals a year to other community support. And I provide feedback to nursing and medical staff, and this can be positive or negative, and I feedback at the piku M&M. So this is just some positive feedback from families. On the whole, feedback is positive, which indicates that we're mainly getting it right. Although we don't get too much negative feedback, the most common comment is that families felt rushed. So although we might not feel like this at the time, it's a reminder that grieving families do need a lot of time around